After studying this module, you shall be able to know what are delusional disorders and how they are different from schizophrenia, mood disorders, etc. Learn about the symptomatology of delusional disorder, to identify diagnostic methods and criteria, and also to understand how to evaluate the various treatment approaches. Delusional disorder was initially known as paranoia. Over the years, the concept of paranoia has undergone many changes. As per Kraepelin's concept of example, paranoia was considered different from schizophrenia, which was dementia precox, and was characterized by the absence of disturbance in thought, defect only in judgment and no change in personality as in the letter. Some like Henderson and Gillespie in 1994 considered paranoia as part of the paranoid spectrum that had paranoia and paranoid schizophrenia at the extremes with an intermediate paraphrenia. In 1977, George Winkover renamed paranoia as delusional disorder. Delusions are defined in the 4th edition of the Diagnostic and Statistical Manual Disorder of the American Psychiatric Association as follows. Delusion is basically a false personal belief based upon incorrect inference about external reality and firmly sustained in spite of what almost everyone else believes and in spite of what constitutes incontrovertible and obvious proof or evidence to the contrary. The belief is not one ordinarily accepted by other members of the person's culture or subculture. When a false belief involves an extreme value judgment, it is regarded as a delusion only when the judgment is so extreme as to defy credibility. Delusional disorder is thus a rare mental illness involving delusions, which are mostly non-bizarre and involve situations that may occur in real life. People with delusional disorders do not necessarily face a lot of maladjustment, while some may be so preoccupied with their delusions that they may face considerable distress. Problems in defining delusional disorders. There was a lot of confusion about categorizing delusional disorder as a distinct disorder. The first problem that is faced while defining delusional disorder is the very definition of delusion. The criteria by which delusions are operationally defined have been debated upon, which basically focus on the ambiguity of the concept of truth and false and the steps used to establish the nature of the statements. Due to this, many alternative definitions of delusions have emerged. Altman in 1988 used descriptive dimensions and provided a list of characteristics to define delusions, which can be briefly put as a belief which seems incredible to other people and is not shared by anybody else, held with firm conviction regardless of presence of contradictory evidence, that leads to emotional preoccupation and is concerned solely with the individual, leads to subjective distress in occupational and social functioning, and no efforts are made by the person to resist this belief. Heidelberg School. Karl Jesper, the founder of the school based in the University of Heidelberg, introduced 3 criteria for the definition of delusions. 1. Subjective certainty. 2. Incorrigibility. And 3. Realistic impossibility of the content. Thus, several definitions of both delusions and delusional disorder exist which lack consensus. This may probably be due to the infrequency of the disorder and due to the fact that patients generally do not actually seek treatment and continue living with the beliefs. It is easily misdiagnosed as delusions form an important part of the symptomatology of various other conditions like schizophrenia, mood affective disorders, drug abuse, etc. Now we must understand the symptoms of delusional disorder. The basic underlying feature of the clinical picture of delusional disorder is clearly the delusional system of the thoughts and beliefs which are rigidly held on to in spite of the contradictory evidence. These are stubborn and mostly false beliefs that are extremely difficult to change or modify. A unique feature is that the facts may be interpreted and reinterpreted to prove and fit to the delusional belief instead of the other way around. Thus, there is a problem in interpretation of facts. Since these delusions are mostly non-bizarre in nature, hence do not lead to major impairment except personal distress unless the event directly involves the delusional beliefs. The delusion in delusional disorder have mostly of 2 basic properties, that is, They are systematized and encapsulated and in varying degrees. Systematization refers to the branching out or network of a set of delusional beliefs gathered around a common theme. Encapsulation refers to the phenomena of thoughts outside the realm of the delusional system being unaffected. So other cognitive abilities stay intact and functional, because of which there is very little functional impairment. Menstreck in 2000 talked about subjective and objective features of the delusional disorder, which are subjective features that include delusions of persecution, reference, grandeur, infidelity, supernatural, love, jealousy, and imposture. While objective features include sensitivity, suspiciousness, moodiness, self-righteousness, irritability, hate, litigiousness, aggressiveness, obstinacy, etc. All these features are quite difficult to define operationally, thus making the judgment of the features depend on merely the extremeness or deviances in the behaviors. Munro in 1992 also provided many clinical features of delusional disorder. He contrasted the feature of delusional and normal moods of thoughts and behavior. In the former, the person is preoccupied with delusional ideas, is over-alert and overdriven, experiences distress, whereas in normal mode, the person is in a relatively calm mood, displays reasonable emotions, and is able to engage in everyday topics. Other symptoms may include various types of hallucinations. Usually, tactile and olfactory are more common and prominent. In delusional disorder, there may be certain types of hallucinations, but unlike schizophrenia, there is no impairment in form of thinking. Now we must have a look at the course and the prognosis of delusional disorder. The course of the disorder is varied. Typically, the course is chronic with high persistence of delusions. Studies are not very consistent, and there are people who suffer severe impairment while others who show a high level of recovery. There are moderate chances of relapses within few months or years. This is mostly because of reluctance to adhere to treatment or medication, which can lead to worse prognosis. People with the disorder generally retain normalcy in many areas of functioning and can do reasonably well with little or no assistance. Diagnosis. The criteria of delusional disorder as per DSM-4 are as follows. A. The essential feature of delusional disorder is the presence of one or more non-bizarre delusions that persist for at least 1 month. B. A diagnosis of delusional disorder is not given if the individual has ever had symptom presentation that met criteria A for schizophrenia. C. Auditory or visual hallucinations, if present, are not prominent. Tactile or olfactory delusions may be present and prominent if they are related to the delusional theme. Apart from the direct impact of the delusions, psychosocial functioning is not impaired and behavior is not markedly delusional disorder or bizarre. D. If mood episodes occur concurrently with the delusions, the total duration of these mood episodes is relatively brief as compared to the total duration of the delusional period. E. The delusions are not due to the direct physiological effects of the substance or a general medical condition, for example, which may occur in Alzheimer's disease, systemic leukoerythematosus, etc. Changes in DSM-5. There are few changes given in DSM-5 in the description and diagnostic criteria of delusional disorder as it was given in DSM-4. Criteria A for delusional disorder no longer has a requirement that the delusions must be non-bizarre. A specifier for bizarre type delusion provides continuity with DSM-4. The demarcation of delusional disorder from psychotic variants of obsessive compulsive disorder and body dysmorphic disorder is explicitly noted with a new exclusion criteria, which states that the symptoms must not be better explained by conditions such as obsessive compulsive or body dysmorphic disorder with absent insight or delusional beliefs. DSM-5 no longer separates delusional disorder from shared delusional disorder. If criteria are met for delusional disorder, then that diagnosis is made. If the diagnosis cannot be made but shared beliefs are present, the diagnosis other specified schizophrenia spectrum and other psychotic disorders is used. The patients are also interviewed with a focus on obtaining valuable information about the person's life, situation and past history. The psychologist or psychiatrist may also obtain information by going through past medical records, interviewing the patient's family, and other significant people in his or her surroundings. The psychologist or psychiatrist may use semi-structured interview called a mental status examination to assess the patient's concentration, memory, and logical thinking. The mental status examination is intended to reveal peculiar thought processes in the patient. The Peter Delusion Inventory is a psychological test that focuses on identifying and understanding the delusional thinking, but its use is more common in research than in common practice. Now we come to the classification of delusional disorder. There are different types of delusional disorders based on the main theme of the delusions experienced. So the types of delusional disorders include erotomanic delusional disorder, where someone with this type of delusional disorder has a strong belief that another person, often someone important or famous, is in love with him or her and has erotic feelings about the patient. The person might also attempt to contact the object of the delusion or stalk them. Another type is grandiose. A person with this type of delusional disorder has an inflated sense of self-worth, power, knowledge, or identity. The person might believe that he or she has some great talent, some supernatural ability, or has made an important discovery. One more type is jealousy. A person with this type of delusional disorder believes and accuses his or her sexual partner with infidelity. Such patient generally believes that his or her partner has been cheating and is in love with some other person. Another type of delusional disorder is persecutory delusional disorder, wherein the patient may believe that they are being mistreated or that someone is spying on them or planning to harm them. They believe that most or some set of people are always conspiring against them. It is not uncommon for people with this type of delusional disorder to make repeated complaints to the legal authorities. Then there is somatic type of delusional disorder. Person with this type of disorder believes that he or she has a physical defect or medical problem. Then also we have mixed type of delusional disorder, wherein the patient may have two or more of the types of delusions listed above. Some other types of delusions may include controlled delusion. In this type, the person believes that his actions, thoughts, and feelings, etc., are all directed and controlled by some external force and not in his or her control. Then there is another type of delusion, that is delusion of reference. This refers to strongly held belief that random and everyday events, objects, behaviors of others, etc., have a particular and unusual personal significance. They may try and find some sort of secret message in these events just for themselves. Delusion of poverty. In this, the person strongly believes that he or she is financially deprived and impoverished. Delusions of guilt. The belief that one is solely responsible for all the misery around him or her. They assume blame for all the catastrophes and mishappenings around them or in places that are not even remotely related to them. They think it's because of their ill deeds that people in the world are suffering. There is one more type, that is nihilistic delusion, a belief that one is dead and does not exist and everything around him is unreal or the world is coming to an end, etc. There is one more type, delusions of misidentification, wherein one develops a strong belief that one's identity, place, etc. has changed. Another broad classification of delusions is mood congruent and mood incongruent delusions. Whether a delusion is mood congruent or incongruent is decided by the relationship between the emotional or affective state and content of the delusion. For example, if a depressed person has delusion of guilt, worthlessness, nihilistic delusion, etc., then it's mood congruent. Whereas if the person has delusion of grandiose accompanying depression, then they are mood incongruent delusions. So delusional disorder, we have one more type, that is induced delusional disorder or folie deux. This is a rare condition where two family members or individuals, usually in a very close relationship, are isolated from others by culture, language, or physical proximity. And they exhibit the same delusions. The person who manifests the delusions first is called the primary case, which in turn influences the other person, known as the secondary case. The former shows true psychotic symptoms, whereas the latter would recover promptly once he or she is separated from the former. The delusional system may be a part of schizophrenia or it may be a primary delusional disorder in itself. Most often it occurs in family members who share close genetic links. Otherwise, the causes are unknown and usually attributed to the social isolation as well. Differential diagnosis. It is very important to rule out the possibilities of delusions originating from other medical problems. Delusions occur in many other disorders, neurological and psychological, thus increasing chances of misdiagnosis. Delusions are manifested as one of the main symptoms in some neurological and medical conditions like Parkinson's disease, Huntington's disease, Alzheimer's disease, and limbic system disorders like epilepsy, cerebrovascular diseases. Psychological disorders like schizophrenia, mood disorders, obsessive compulsive disorders are also constituted with delusions as main feature. Delusions are caused in cases of substance abuse and drugs. Example in consumers of cocaine, amphetamines, and the drugs like antidepressants, anti-Parkinson agents, etc. Hence, it is important to carefully compare the symptoms and diagnose the disorder. That is, delusional disorder can be distinguished from schizophrenia by a non-bizarre quality of delusions and taking into account the other symptoms of schizophrenia. Somatoform type of delusional disorder is distinguished from depression by the lack of pervasive quality of depressive mood. Many also can have in common persecutory delusions but can be distinguished by the other symptoms accompanying mania like hyperactivity, poor concentration, uninhibited behaviors, etc. Now we must understand the etiology of the delusional disorder, wherein first we discuss the biological approaches, under which we would first discuss the brain defects and neurological causes. There has been a major focus on the role of hemisphere specialization and the limbic system to find causes of delusions. More often than not, defects in the left temporal lobe has been associated with hallucinatory and delusional states, while on the other hand, damage in the right parietal lobe has frequently caused two specific types of abnormal beliefs, which are Capgras syndrome and anosognosia. Cummings in 1985 emphasized the role of limbic system and the basal ganglia in the development of delusions, and these mediate mood and motivation. Stuss and Benson in 1986 have asserted that damage of prefrontal areas of the brain has role in the development of delusions and reported in 1995 cases in which delusions were accompanied by the same due to accidental disease. If we see the role of neurotransmitters, it has been scientifically proven that excess of dopamine has been found to cause the hallucinations and delusions. Now comes genetics. Frequently in psychiatry, a question that is often raised is whether delusional disorders are related to schizophrenia or mood disorders, or whether they represent a separate group of disorders. Studies show that rates of schizophrenia and mood disorders in relatives of delusional disorder patients does not differ from the prevalence rates in the general population. Only if they have been related in any way, the incidences should have shown a higher rate as compared to general population. Thus, this shows that delusional disorders are the distinct groups of disorders. It has been found that the involvement of genetic variation in the dopamine D4 receptor gene leads to increased vulnerability of delusional disorders. Now we must understand psychological approaches. Delusional disorders have been etiologically traced to majorly biological causes. However, some psychological theories do exist. Delusional disorder is a result of cognitive defect. Several studies have been done to ascertain whether there actually exists a cognitive impairment in belief formation in patients with delusional disorder as compared to the process of belief formation found in normal individuals. Various studies have been done in order to find if some kind of anomaly in the cognitive processes is involved in the formation of beliefs. However, a reasoning defect in deluded patient has not been evident yet. Thus, it further supports the possibility that actually no defect is present and the cognition that produce these delusions are normal. Delusions and time sense. Melchers and Freeman in 1975 proposed a cybernetic model for the formation of delusions, which points at temporal disturbance of formal thought as the primary cause of delusions. Experiencing disintegration of the temporal sequence of thoughts makes patient feel as if they are losing control, which may be labeled as mysterious. This may further lead to anger and fear, leading to further disorientation and cause them to behave in a holistic manner. Delusion and attention. In 1903, Burrs proposed that paranoid patients have attentional defects which serve as causative factor for delusion. Delusions and perception. Pavlov in 1934 had proposed first theory that asserted that the delusion of reference and control were due to perceptual disturbances which he felt occurred due to pathological inertness of the cells of sensory cortex. To compensate for these inertness, other cells are hyperaroused, thus leading to irrelevant ideas to find their way to consciousness. Delusions may develop in patients with hearing deficits. Incidences of visual defects have also been found more in delusional disorder patients. To prove this, Zimbardo, Anderson and Cabot in 1981 demonstrated that hypnotically induced hearing loss in normal individuals led to higher scores on paranoia scale of MMPI. Freud's hypothesis. Freud's psychoanalytical perspective asserts that the delusion stemmed from repressed homosexual tendencies. He hypothesized this based on a case of a German lawyer. However, his theory has been criticized for many reasons that include inconsistency, overlooking of facts, inclusion of only 4 kinds of delusions, and that this approach is unscientific and biased. Now we go through the epidemiology of delusional disorders, wherein first we discuss the prevalence. The rates of prevalence show that delusional disorder is uncommon but not rare. Estimates of general population show that the prevalence rate is almost 24 to 30 cases per 1 lakh people. The incidence rates have been estimated to be 0.7 to 3.0 new cases per 1 lakh people. In India, 5% of the cases have paranoia out of all the patients with delusions. Age of onset. Delusional disorders are most likely to appear during midlife. Both age of onset and age of admission peak around the age of 40 to 50. Sex differences. Not much difference has been found, with both sexes being affected almost equally. Incidence rates in females are slightly higher, with 55% of the first admission patients being women. Other demographic factors. Marital status. 32% cases of delusional disorder were found to be unmarried. Educational qualification. The delusional disorder patients were found to be more poorly educated as compared to other affective disorders. Pre-morbid personality. Patients with delusional disorder are more likely to be extrovert, dominant, and hypersensitive. Treatment. Wherein first we'll be discussing the pharmacological treatment available for delusional disorder. We have oral neuroleptics like PSY that are being promoted to be therapeutically specific for delusional disorder as compared to other psychotic drugs. Srinivasan et al. In 1994 from India came up with treatment using trifluprezine, haloperidol, chlorpromazine and electroconvulsive therapy. Delusional disorder treatment often involves the use of atypical antipsychotic medicines like risperidone, quetiapine and olanzapine are some examples of the same. Psychological treatment. There are various psychotherapies available, but in any psychotherapy for delusional disorder, establishing a trusting relationship with the client is the key, like that of any psychotherapy. The therapist must reassure to be compassionate to the client to facilitate the process of treatment. It has been accepted that to confront the client about his or her delusions is not a good idea, and this can rather make them angry and hostile instead of leading to conviction about the delusional nature of the beliefs. Initially, the therapist should neither agree with nor challenge the patient's delusions. Cognitive therapy has yielded good results when it comes to reducing delusional thinking by modifying the beliefs itself. Voicing counter arguments against their delusional belief and develop alternative explanation for their experiences. Beck and Shadwick and Lowe employed these strategies and reported successful results. Now we quickly go through the summary of this chapter. Delusional disorder was initially known as paranoia. Delusional disorder is thus a rare mental illness involving delusions, which are mostly non-bizarre and involve situations that may occur in real life. Defining delusional disorder has led to a lot of debate regarding the very definition of delusions. The main aspect of the clinical picture of delusional disorder is the delusional system of thoughts and beliefs which are rigidly held on to in spite of contradictory evidence. Diagnosis is done based on DSM-4-TR and DSM-5 criteria accompanied by the interviews and administration of psychological tests. The types of delusional disorder include erotomanic, grandiose, jealous, persecutory, somatic, and mixed type. Biological approaches mainly define the etiology of delusional disorder. Treatment involves administration of neuroleptics combined with the cognitive therapy.